Great, awesome. Thank you for everyone for coming. Welcome to our student speaker series. I'm going to share my screen now and we can get going. All right, everyone can see my screen? Awesome. So yes, as I said, this is the Association of Cannabinoid Specialists. This is part of our student education series, and tonight's event is Cannabis for Sexual Health. I want to do a quick plug for our ACS student memberships. They are free and they are awesome. You get an annual subscription to the Cannabis and Cannabinoid Research, access to clinical resources, member pricing for educational materials and events, opportunities for networking and mentorship, and representation in cannabis advocacy at efforts at the federal and local level. So it's pretty exciting stuff. Lasts for a whole year. And again, it's free. So please contact us and join. Tonight's speakers, our first speaker tonight is Dr. Jordan Tishler, a cannabinoid specialist physician. He is the president of the ACS and faculty at Harvard Medical School and Mass General Brigham. He was awarded Clinician of the Year by Americans for Safe Access and Marfan Society. He is advisor to the Massachusetts Cannabis Commission and Council for Federal Cannabis Regulation. Our second presenter of the evening is Suzanne Mulvehill, a clinical sexologist, orgasmologist, PhD candidate, and the executive director of the Female Orgasm Research Institute, which is a 501c3 nonprofit organization. Through the Institute, Ms. Mulvehill is committed to conducting research to identify scientifically based treatments to help women heal orgasm difficulty, which affects up to 41% of women worldwide, when this statistic has been unchanged for 50 years. Ms. Mulvehill has presented research theories and literature reviews that reveal that cannabis may be a treatment for female orgasm difficulty. She co-presented her cannabis and female orgasm research at the 2021 World Conference on Sexual Medicine, and for the last 3 years at the Cannabis Clinical Outcomes Research Conference. I think I speak for everyone when I say I'm very excited for this presentation. And Dr. Tishler, if you'd like to take it away, I will stop sharing my screen so you can share yours.
Thank you very much, McKenna. Let me start by saying that Ms. Mulvehill will be Dr. Mulvehill in exactly 9 days or something. Don't hold me to the math, but it's short days. So there we go. Now let's see if I can actually share my screen and get us to what we need. Hang on a sec. Put this into view. This is the view you guys want to see. All right, you're seeing the slides, yes? Excellent. All right, so we're going to talk a little bit about sex and cannabis, and specifically the topic of intimacy. And I will start by saying that I view myself this evening as sort of the introduction to this topic, and quite frankly, sort of mostly the cheerleader. And then Ms. soon-to-be Dr. Mulvehill will actually get into the bulk of her research that I participate in. You heard my bio very briefly. Mostly, I want to say I came into this field after being an emergency room doc for many years at the VA, and went on to start practicing this sort of medicine. And very early on in my practice of cannabinoid medicine, I got very interested in the intersection of cannabis and sexuality. And honestly, I don't know that I can recall what prompted that, other than I seem to recall reading an article, not a scientific article, in which there were a bunch of women from California who had grown up working as young adults on a cannabis producing commune, writing about their experiences of getting particularly aroused while they were harvesting cannabis. Well, come to find out, of course, that that's a great story, but actually biochemically not really relevant. But anyhow, that was the genesis of my interest in this field. You probably all know that I founded the Association of Cannabinoid Specialists, which obviously is why we're all here today. But most importantly, I want to just say that I have no conflicts of interest that I should mention to you this evening. And it would be nice if these things went forward. So let's start with some myths. And the first myth here is that women aren't interested in sex. And I think that tonight's attendance proves that to be patently false. But what we know in surveys of women who are sexually active, the numbers are 65 to 70% of women between the ages of 18 and 50. This decreases slightly down to 20 to 40% by age 90, right? So, you know, if anybody is out there who's 90 and still getting it on, right, God bless them. But another staggering statistic here is that female sexual dysfunction occurs in huge numbers, around 40%. And Suzanne will talk more about that specifically around orgasm. And this, you know, presents then as a major public health issue affecting the well-being of women in the United States. Thinking about those who possess penises, we also have to understand that we have a certain view of male sexuality in this country that is not particularly healthy either. And that we know that sexual issues are more than just erectile dysfunction, which has certainly been hyped in the world of Hollywood and with regard to a particular sort of class of medications. But male sexual issues occur at about 50% across all age ranges. Most common complaint is early finish at about 30% of males. Lack of desire, something that's not particularly discussed in our society, occurs in around 15 to 20%. And erectile dysfunction is only really an issue in an age-dependent fashion, starting at around 7% and up to about 18% for men over the age of 50. And we have to remember that there is only one class of medications for any of these male issues, that being the phosphodiesterase 5 inhibitors like Viagra and Cialis. They only work on erectile dysfunction. They do nothing for other male issues, and they do, of course, nothing for female issues. And sexual dysfunction is a tremendous effect on people's lives in an adverse sense. These adverse outcomes include poor self-esteem, mood instability and depression, and strained relationships with partners. Unfortunately, it turns out that despite the prevalence of these issues, most people don't get the care that they need. Very few people seek or receive care for their sexuality issues. In women, it's about 35%, which is not a great number, but it's better than zero. And in men, it's less than 25% seek and receive sexual care for their sexual issues. And if we factor out those who are coming for the Viagras, then that number becomes basically unmeasurable. We also have to remember that women are better at seeking medical care than men in general across the board.
Did we fart? But I probably won't be able to leave until.
Thank you. And so let us, as a preamble to all of the rest of the discussion, let's talk a little bit about our understanding of how sexuality works. Now, this slide is kind of the end of the story, but what we really need to understand is that our understanding of sexuality really only began in the 1960s, right, with Masters and Johnson. And they described four-phase response to human sexual stimulation. Their terms were excitement, plateau, orgasm, and resolution. It's a little bit more of a clinical description that I think is helpful. But it turns out that they're thinking about these in these four phases turns out to be a useful construct, and it's reasonably accurate across all genders, with the proviso that it only really applies when things are working properly. And it's really not a sophisticated enough model to start to understand why things might not work so well. In 2001, Rosemary Basson introduced her concept, which really sort of encompassed the Masters and Johnson scheme, but this was sort of almost sort of a side note of kind of how things end if things go well, but there was much more complex understanding of the preamble of that, particularly in terms of what effects have on the psyches of the partners and in particular of women. Now, the only problem with the Basson model is that you try to put it on a slide, it looks like spaghetti thrown at the wall because there are so many factors and they all influence each other, and so there are arrows going everywhere. So in some ways, the concepts are great, but the representation is challenging. So this leads us to the slide that you actually see, which is the biopsychosocial understanding, and it really kind of looks at the influences on sexuality in sort of 4 domains. So you can see that there are biological factors, right? Physical health, do the neurons to the penis work, right? What is the vasculature? That sort of stuff. Fairly basic stuff. Do you have high blood pressure and therefore take medicines that decrease your ability to get sexually aroused? Those sorts of things. Then we can look at the psychology aspect of it. How do I feel as a person about myself, as my sexuality? Am I able to engage in this kind of activity and really, engage fully? Then there's the interpersonal. How do I feel about my potential partner? Is this somebody that I would consider really going to bed with? Is there something about them that rubs me the wrong way? Am I tired of listening to my wife of 40 years? I mean, all of those things can factor into those interpersonal things that can either promote or inhibit the sexual connection. And then, of course, there's the sociocultural, which there's a long history of various traditions, from the Puritans to the Catholic Church, and I'm sure there are many others that don't come to mind at the moment, where we have this kind of social and or cultural imposition of values that may be contrary to the health of that individual and their sexual engagement. So this reflects kind of on that left column where we are in terms of thinking about the 4 phases. We talk about desire. This is also sometimes called libido. Arousal, this is about getting erections or lubrication, etc. Orgasms, we see, I think we have a pretty good idea of what that is. And satisfaction is sort of that post-coital intimacy that hopefully is part of the process. And we can see that there is essentially a set of dysfunction in males and females that correspond to each of those phases. So, interestingly enough, cannabis can help with these sexual problems. Otherwise, we wouldn't really be here talking about it, would we? So one of the things that's interesting is that there's evidence that cannabis can clearly benefit women in all of the 4 phases, right? Desire, arousal, orgasm, and satisfaction. Cannabis has been shown to increase female interest in sexual activity, both receptive, meaning somebody else is saying, hey, let's do it, and also proceptive, meaning that she might say to somebody, hey, let's do it. And then we also see that it has benefit to the arousal process with lubrication and relaxation of vaginal musculature. And then we've also seen data that cannabis can heighten climax in women and may prolong both the frequency and the intensity of orgasm. And this is where I usually insert a little story about some of the ways we know this. So in the early 2010s, I don't want to be too specific about the date, there was an intrepid group of researchers in London who wanted to look at the effect of cannabis, or actually at this time they were using THC, on sexuality. So they built an orgasm meter. And now you can actually buy these things off the shelf, thanks to some of the toy manufacturers. Don't know how well those work, but at this time they built this device and it measured orgasm and lubrication. And not surprisingly, this was a rather phallic object. And then they went out to recruit female subjects. And they recruited in a bunch of women, and the idea was that the women would insert this device that would measure their sexual response. And the researchers kind of did two phases, right? So they showed the women something boring like CNN, and not surprisingly, not much happened. And then they showed some pornography, and actually not a lot happened there either. So then they got the THC, which oddly enough in this setting was by IV infusion. But leaving that aside, then while the women were, high on the THC, they showed them the same CNN, again, nothing. And then they showed the pornography, and suddenly there was a brisk response, right? Just proving that cannabis can make even bad pornography interesting. But that's the kind of level at which we have data. Cannabis for sexuality in males is a little bit more complicated, shall we say. In females, we haven't really talked about dosing per se, because while just enough is always probably the right measure, in women there's more leeway in terms of the actual ingested dose, without a whole lot of sort of paradoxical degradation of the experience. In men, it's more complicated because, frankly speaking, if men are not still able to kind of focus specifically on the mechanics of sexuality, then things like their erections cease. So that we've found that cannabis certainly can increase desire in men, and in small doses can help with arousal, as well as issues around either premature or overly delayed orgasm. But again, if the dose is too high, then it impedes all of that. And so with males, we need to be a little bit more careful. Generally speaking, data suggest that the response in the satisfaction phase is good as it relates to cannabis. But again, this assumes a complete sexual act. So at the end of all of this, I think we can say, yes, cannabis does help with sexuality and intimacy. It can help across all four domains of desire, arousal, orgasm, and satisfaction. And overall, the intimacy, that feeling of connectedness, is enhanced. In men, however, we need to be a little bit more careful about the doses, and low doses are beneficial compared to higher doses. I too want to take a moment to plug the Association of Cannabinoid Specialists. Our goals in life, as many of you are already aware, are to increase the standard of care for patients, to make sure that they're getting what they need. And we do this by making sure that we have education available to physicians and other clinicians who don't take care of patients using these medications, as well as more intensive and deeper education for those who do practice cannabinoid medicine. We work with dispensaries and product manufacturers to make the products that are better and safer for our patients. We want to encourage research and certainly spend a lot of time focused on law and policy and regulation, both at the state level, where this morning I spoke to the legislators in Illinois, for example. But really our focus is trying to come up with a unified and rational set of policies for the United States at the federal level, and then helping to disseminate those throughout other countries. In the last slide from me tonight, I just say, if you're looking for references, you can follow this bit.ly link. I think there are probably only a couple on sexuality in there, but you can always reach out to me at doc@inhalemd.com or president@cannaspecialist.org, and I'd be happy to give you answers if you have questions, or references if you want those. So that's really what I have to tell you this evening. And from here, I will stop the share and we can go and hear from Suzanne. Yes, I see that Sarah has put in the chat that if people have questions, they should put them in the chat and we will look forward to them. So keep them coming.
Thank you very much, Dr. Tishler, for your presentation. Thank you, Sarah and Kelsey and McKenna for all inviting me here. Let me just make my screen a little bigger and share with you on the full screen here. There we go. Okay, so I had just finished my research doing a study on cannabis and female orgasm, and in particular, asking the question, does cannabis, it moved without me moving it actually, does cannabis actually help women orgasm? And looking at the research, one of the first things in doing the literature review I found out was that there was 50 years of research that actually has said that cannabis does help women orgasm, and it does help increase, as Dr. Tishler talked about, the frequency, the intensity, the satisfaction of orgasm, but there were no studies that ever looked at dichotomizing women with and without an orgasm problem. So that's where my research came in really realizing that this persistently high percentage of women that have orgasm problems, and knowing that in a recent study that statistic hasn't changed for 50 years, despite the number of sex therapists that there are, despite the changes in masturbation habits, the exception of sex, meaning it's more that people think of sex as being more free, and really the paucity of treatments that are available. There's one validated treatment for what is now called female orgasm disorders. It used to be called inhibited female orgasm. Before that, it had a different name. And then there's different levels of orgasm disorder that, I'll just go over the three of them very briefly. The first one is anorgasmia, a woman who's never had an orgasm in her life. They also call that lifelong FOD. The second one is acquired FOD, which means women who used to be able to orgasm but cannot any longer. And often that is attributed to medication. And the third one is what's called situational FOD, which means women who can orgasm in some situations, but not others. And in this study, primarily it meant, and in general, what I've learned from interviewing women is that it means not being able to orgasm during partnered sex. So cannabis being suggested as a treatment for 50 years, it was, okay, let's go take a look. And the research that has been conducted, the recent research was all quantitative, and the past research was mainly qualitative with some quantitative studies. But this study, the study that I did was both, was a mixed methods. And what I'm mainly going to share with you today is going to be the quantitative results. So the objective of the study, as I was sharing, was really to look at what is the effect of cannabis use before partnered sex on women with and without orgasm difficulty in dichotomizing. And that was a decision in designing the research that came as a result really of the literature review, in seeing what problems do women have. Do they have this orgasm problem or not? And we really narrowed it down specifically to partnered sex, not masturbation, because this situational FOD is the number one type of orgasm difficulty that women have. So we thought, let's really tighten this up and make sure we're measuring exactly what we want to measure. So the materials and methods for this study was, it's an IRB observational study that was conducted between March and November of last year. And, Dr. Tishler, I have to share, was my dissertation advisor for these last 4 years and really contributed heavily to helping design and this study with his expertise in with cannabis and helping patients with these issues. It was we used Qualtrics, which was an online database to conduct the study and collecting basic baseline demographics that was necessary, their cannabis use behavior, what their masturbation habits were, what their sexual partner sex habits were. And the core of it was really what's called the Female Sexual Function Index, the FSFI, which is a measurement that looks specifically at sexual dysfunction in women. And we just use the orgasm subscale questions with and without, using it with and without cannabis. So we measured orgasm frequency, asking the question, for example, what's your orgasm frequency in the last 30 days? So that's an important piece, because we didn't have any women in the study that we'll see that in the next slide, but we asked them specifically about orgasm frequency, orgasm difficulty, and orgasm satisfaction during partnered sex with and without cannabis. So the inclusion, who was included? So this was also, and who was excluded, in designing this study, making sure we wanted to get clean data. Women 18 years of age and up, partnered sex in the last 30 days, cannabis use in the last 30 days. We asked a question about their genitalia, if they were born with female genitalia. And I have to say too, the inclusion criteria, as we went through the study, we actually excluded not only breastfeeding and pregnant, use of other recreational substances in the last 30 days, again, to get clean data, but also if they hadn't used cannabis during sex within the last 30 days. Or no, that's not true. Let me back that up. They had to have used cannabis before sex, period. If they never used cannabis before sex, they were excluded from the study. There were about 7 women that had never used cannabis. They used cannabis, yes, in the last 30 days. They may have used it for the last 10 years. But if they never used it during partnered sex, we were measuring with and without. So they were excluded from the study. So overall, we had 1,037 responses, and I have to share with you that we had, and near the end, we had in October of last year, I think we had at that point still about 200 people had completed this survey. And I had received a random text on my phone from Reddit about take a survey. And I was like, what is that? Take a survey. Well, that led me to Reddit, which I found out had 54 million people on Reddit every day, and found several places where I could post and ask permission to post the survey. And in 24 hours, I had like 400 responses. I mean, at one point there was one survey permitted being completed. So that really facilitated the getting the number of survey responses that we had. We ended up with the 387 valid surveys. 52%, there was 202 of those women that reported orgasm difficulty during partnered sex. What was really interesting about this was that difficulty is really a subjective word. So in looking at the results really defined whether there was difficulty or not. And what I mean by that is a woman that it became very obvious in looking at the results, women who had a problem orgasming, the majority of them almost never orgasmed without cannabis. So that was one of the, there were about 7 women that got moved from saying that they didn't have difficulty to that they really did because of their answers and the way they answered, and about 7 women who said they did have difficulty and they really didn't, according to their responses. For example, one woman who'd said, to give you how this actually worked, a woman would say, I don't have any problems having orgasm. But her answers were, I almost never orgasm without cannabis, which was the answer that the majority of women gave when they said they had a problem. So, but that also showed confidence, which is another whole piece of this study, that a woman who can almost never orgasm without cannabis and almost always with cannabis and say, listen, I don't have a problem orgasming. So, because cannabis helped her actually improve her confidence. So she got moved without her knowing about it, because this was all anonymous, into the, yes, she has a problem because she answered that way. So this was a really interesting piece that, as you see, 45% were between the ages of 25 and 34, 75% were reported their race as white, 82% married or in a relationship, 71% reported this situational orgasm difficulty, as I shared, which was that they had difficulty having orgasm during partnered sex. But this piece was really fascinating, that 77 reported no other sexual issues besides orgasm. When, that just showed really what Dr. Tishler was talking about earlier, how it helps in other areas of desire and arousal, that it's a multimodal kind of treatment, in that they don't have any other problems having with their sexuality. And we'll see further as we come along with some of the main outcomes, how it increased orgasm frequency, ease, and satisfaction. All 3 of those were all statistically significant. 72% of the women increased orgasm frequency, 71% orgasm ease, 67% increased orgasm satisfaction, which are really pretty substantial results when you think about the fact that the statistic hasn't changed for 50 years of the number of women who have orgasm difficulty. So, and the fact that it had been recommended for a treatment, cannabis has been recommended, in research back, Dr. Dolly, and the references are in the back of the study. You can have a copy of them as well, where they already were starting to recommend back, like in 1979, that cannabis be a treatment for sexual disorders. So we'll talk about that in a little bit further. So here's the first graph or the chart, where this is a chart of orgasm frequency for the women with FOD, with orgasm difficulty, with and without cannabis before sex. So when I talked about, if you look at the almost never or never, and the no cannabis, which is the far right side, almost 35% of the women who have orgasm difficulty almost never orgasm without cannabis, which is almost the same statistic as the 41% we saw in the very beginning who say, nope, we don't orgasm. But when you give cannabis to these women, almost 40% of them almost always orgasm when they use cannabis before partnered sex. I mean, that is remarkable, and that is a statistically significant result. So it's clear that, and when you look at almost always, there's no women that are going to almost always orgasm with no cannabis. I mean, this could be a different kind of a chart as well, in the sense that no cannabis, no almost always orgasming for these women who have orgasm difficulty. Interestingly, and I don't have a chart or a graph or a figure on this, women who don't have a problem orgasming almost always orgasm with or without cannabis. It's not a problem. The cannabis doesn't really make a difference in the frequency for women who have no problem with orgasming. Okay, so the next one, orgasm satisfaction. I'm going to take you to the first, if you look at the very satisfied, which is on the far left side with cannabis, and look at the difference of the very satisfied without cannabis. So we're about 40% of the women who have orgasm difficulty, 40% are very satisfied, where less than 5%, which makes sense because of the previous figure that we saw, hardly any women, almost every, they struggle. 40% do not orgasm when they don't use cannabis. So this was also a statistically significant result. And the orgasm ease was another one that I don't have a figure for that one, but that was also found in a study. Dr. Weeb she's out of Canada. They did a study back in 2019 and found that 50% of the people that were using cannabis had an easier time orgasming when they used it. So that was a backup to what we did with orgasm ease. So some secondary outcomes. So the frequency of using cannabis before sex increased orgasm frequency. And this is for women who reported orgasm difficulty. This particular finding has been found also for 50 years. Dr. Eric Good, who conducted the first cannabis and sex study back in 1969, he had already touched on this frequency of cannabis use. Dr. Becky Lynn in 2019 recently had a similar result. Actually, her particular result was that more women who use cannabis more frequently were 2.10 times more likely to orgasm. The frequency of cannabis also was shown by a study by Dr. Kasman that for each step up of cannabis use, meaning from once a week to maybe twice a week or once a month to each time it went up a step, female sexual dysfunction overall in all of the realms of sexual dysfunction went down by 21%. So frequency of cannabis use is heavily tied to sexual functioning for women. And that was also found in a study by Gorkala, I think I can't quite pronounce his name, but he's one of the researchers that found that it's common for women, more common for women is what he said. The reasons for cannabis use. So we asked about the reasons. What is the main reason that they're taking and using cannabis? The main reason was actually relaxation, which was found in the Kasman study as well. But the women who were using it for pain and sex, meaning they were taking it because of often it's sexual pain that they were having, or they were taking it because they wanted to have, particularly for sex, they had the most positive orgasm response. I mean, obviously the women that were taking it for sleeping, like I measured it for women sleeping, they're sleeping. No, it didn't have a more positive orgasm response when they were primarily using cannabis to go to sleep. Their main primary intake method was statistically significant for all women, with smoking being the primary intake method. And I can share with you that on the qualitative side, when I interviewed women, I mean, how particular they were about their intake method. One woman would make brownies and, I use 1/4 of a brownie 30 minutes before sex, or I use, so they were women who, I interviewed, which could have been a limitation because these were really women who knew what they were doing. They had it down. They knew what they were doing. All women who reported a mental health diagnosis. So as I shared with you in the beginning, that we looked at women with FOD and without, and the results for both groups. This is a result for both groups. So all women with or without FOD who reported a mental health diagnosis or a sexual abuse history had a statistically significant, more positive orgasm response. That was pretty revealing. And the number of women with FOD reported considerably more mental health issues, prescription drug use, sexual abuse histories. It was quite dramatic. And in fact, it's here. Women with orgasm difficulty compared to women without orgasm difficulty. And this is really important because, often we look at orgasm is talked about as just something that's for pleasure for women. It's I had a conversation with my own attorney of 30 years in the last week, and he was like, I don't think public funding should go for women who have orgasm difficulty, because it's just too bad that they can't orgasm. But when I gave him these statistics, that 52% more women that had orgasm difficulty had PTSD, 32% more with sexual abuse histories. And the number one sexual complaint for a woman who has a sexual abuse history is difficulty orgasming. So, it becomes a health issue. It's not about pleasure, it's about health. 29% more depressive disorders, the number of women. So women were able to, in the study, check off the boxes of their number of mental health issues. The women with the orgasm difficulty had 24%, had checked off 24% more boxes, 22% more prescription drug use. It was staggering, this particular piece of information that, from a public policy perspective and a mental health perspective, it's pretty clear that orgasm is an important component of sexual health and mental health and overall health. So the limitations, it didn't help all women orgasm. 4% reported never having had an orgasm. Now, I have since gone and looked back into their particular answers, and the percentage of this was who never had an orgasm. It's too much information for me to go into right here, but if we know overall that the statistic is 10 to 15% of women who never had an orgasm, this study, women who use cannabis, the percentage of women who use cannabis have less chances of not having an orgasm. And women commented in the study about cannabis. I had my first orgasm on cannabis. Or a woman who had what was called acquired. She had a cyst in her ovary. She used cannabis the first time. She hadn't had an orgasm in a couple of years, and she thought it was related to this cyst being removed. Cannabis, her orgasm came back. Results may not be generalizable. Women who rarely or do not use cannabis before sex, like we said, I didn't measure women who did not use it at all, but it was clear that women who rarely used it didn't have as good of results. And not generalizable to women who never had an orgasm. It may not be. We'd have to look at a study to really measure that. We don't truly know whether that's true or not. And then knowing that the cultivar, the chemotype, and the dose were not evaluated, which really in an RCT, looking at dose in particular and looking at these limitations and using this information from this study to design an RCT would be very, very helpful. Like, why did it help some women immediately? And why did it take some women longer? These are some of the questions that we would want to ask in looking forward, in moving forward into the study, into an RCT. So the conclusion really is that cannabis-based treatment does deserve additional study and being looked at as a treatment for FOD. And RCTs are obviously needed. And since preparing this particular presentation, I've already contacted New Mexico. Dr. Tishler has written a letter of support and has been in contact for getting FOD added as a condition of treatment first in New Mexico, a state that has petitions. You can petition the state, and really working towards getting state by state. We've also written letters for Connecticut. I created some states allow cannabis to be for conditions to be petitioned to the state. So I've been working on developing that list and know which ones to go to next. And really, for the students that might be interested, these are the references for the study. You're welcome to go to I only have the email here, but if you went to femaleorgasmresearch.org, there's a pop-up right on the screen that says, you know, if you'd like to support getting cannabis added as a condition of treatment, to please complete. And it's you put your name in and by state. I've had a number of people so far sign up because I think it'd be helpful in having been an elected official and having lobbied for public policy changes. It's helpful to get feedback from people that actually would want it. So that really concludes my presentation. Let me stop the share. And thank you all for listening. And thank you. Thank you. Thank you very much, Dr. Tishler. Thank you.
All right, McKenna, where are we?
Right. Well, we seem to have some time left for Q&A. I know we have some questions in the chat. Let's see. What systemic approach do you employ to discern the threshold between a high and low dosage when it comes to cannabis products?
Yeah, that's an interesting question. And it gets at a much larger question that we really haven't spent any time on this evening, which is sort of the practicalities of how you would instruct somebody to do this. The short answer is that inhalation is a best approach because of the timing of the way it works. When I say inhalation, I don't actually mean smoking, though that is certainly what we've seen as the primary approach in this study. Of course, those people weren't being guided in any fashion. So when I deal with patients about this, I tend to suggest flower vaporization because it's the safest form of inhalation. And then I have sort of a whole process by which I help people sort of get used to the cannabis and get used to solo sexual congress prior to getting into a partnered type of situation. But really to get at the question that was asked, if you put cannabis that is between 15 and 20% THC into the vaporizer and you take a full deep breath, you're getting about 5 milligrams of THC in each puff. And that helps quantify where we're going with this. And then I would typically describe a titration process to the patient, which starts with, start with one puff and let's see how it goes, and then move on from there, all in the setting of a relaxed environment with no partner involved, where there's purely a get to know cannabis and get to know your body on cannabis kind of approach before then finalizing sort of the dosing and moving on to partnered relationship. Now, you'll notice that I didn't talk about males or females in that setting because other than being more cautious about the dose escalation, the gender isn't relevant to that.
Awesome, great. I think this question was somewhat answered, just asking about how the respondents ingested the cannabis. We did talk about how it's a little bit more on inhalation, but Suzanne, if you want to speak more on that.
Yeah, mainly it was edibles and smoking was number one. Edibles was another type. I don't have the exact percentages offhand of that, but we could get them. Vaping was another one. But smoking was like, I know that was like over 70% was smoking. If that answers the question. I mean, I don't know, just, smoking cannabis, I guess, versus using what Dr. Tishler had just shared was like I think that's a vape, right? What you just showed was a vape.
Flower vapor. Right, which is not the same. Whipping out my other props, don't get me started. Right, this is a vape. This is a vaporizer.
Got it. A vaporizer. Okay, vaporizer.
Okay. There's also a question brought up here about topicals, and that's something I would take a moment to address. Cannabis topicals are often talked a lot about. And there is some data to suggest that applying cannabinoids to the vulva and into the vagina can cause some relaxation of the smooth muscle in the vagina. It can increase sensitivity of the genitalia. But that's about what we can see. And the two things that stem from that. The first is that unlike a true lube where you sort of put it in place and go to town, the cannabinoids don't work that quickly. And so you have to sort of lube up about 45 minutes ahead of time. So in terms of practicality, it's not super helpful. And then I think, much more importantly, as we've talked about, the balance of sexuality, as I often say, occurs between the ears and not between the legs. So if we're putting the cannabis down there, we're missing most of the boat. And, again, thinking about some of the data that Suzanne has shown us about the issues around orgasm and satisfaction coupled with medication or mental health issues, we can start to see that all of these things are really above the neck, even though we have a tendency to refer them down to the genitalia. So putting the cannabis down there is not really going to be particularly effective.
I know you mentioned your bit.ly earlier, and Suzanne, you shared your list of resources, but there's a question about if there's a link for resources and research that covers both males and females. If either of you want to touch on that any further.
Well, I guess from I have the Female Orgasm Research Institute. So, I don't have a combination of both. They're welcome. There's a library, there's an online library on the website, femaleorgasmresearch.org. And, I think that might be something that I would add. I mean, if there's going to be interest for that. Dr. Tishler, you may have an answer or some resources for that as well. It's a good question.
Sorry, I was reading another question when this question got posed. The bottom line here is certainly Suzanne's library on female orgasm disorder is very, very extensive and perhaps more extensive than the AES library, but the AES library does have sort of that broader research. So if you're looking for stuff that encompasses males and females, you can start with the clinical reference library, which is a member benefit. All of you students should become members, and then for free, and you've got access to that. But actually, Suzanne, we should circle back and put your references into the clinical reference library or some subset of them.
I did share a list of them with Sarah, I think, of all the references that are attached here, just the actual articles. I'll make sure that you have the actual articles for your library. Yeah.
Yeah. Kelsey, can you make a note, please, to pass this information from Suzanne to Suraj, and then we can sort out what goes where, and then you can put it on the website.
Yep, no problem.
Awesome. By the way, Kelsey Engvik, the best.
Facts.
Somebody had asked a question about what research has been done in the LGBTQ plus arena, with several other groups mentioned as well. And I'll have to say none. Nobody has looked at this at all. We're just barely scratching the surface for other more traditionally oriented groups. I don't know, I'm stumbling all over my words here, and I apologize for that. But in any case, we'll get there. But as you're all aware, it's hard to do research in cannabis. It's hard to do research in sexuality, and it's damn near impossible to do it at the intersection. So I'm hopeful that we can expand the definitions here.
Can I add one comment, Dr. Tishler? That in the peer review, we submitted this to the Journal of Sexual Medicine, and one of the peer reviews that came back, my study did have about 50% of the respondents were LGBTQ, that I need to put that in a, you know, it has a different flavor. I don't want to say flavor, but it's even though the study didn't target that group, the responses came from that group, from LGBTQ community. So, you know, it's actually some good information to have if I can you know, this is special results that came, not special, but the majority came from this
Subgroup
the
analysis.
group. Yeah.
And that's sort of to your second question there, which is that we did not go look for heterosexuals in this case, and we got a mixed panel. We were only interested in yes or no sexual or orgasm issue, and yes or no cannabis, or yes cannabis. Somebody asks, where can we find the website that tries to get cannabis recognized as a treatment for FOD?
I'm still developing it. It's womenscp.org is the name of the website. But for now, there's a pop-up right on femaleorgasmresearch.org. As soon as you go to that page, Female Orgasm Research, there is a pop-up that says, you know, sign up to get state by state. So there you can put your name in and your state, and it goes right into MailChimp, and I check it like regularly. So, and we'll be in touch when your state, you know, just you can send me a private email too if you're interested in getting involved in your state. Some states, like I said, allow the petitions, and some are closed. So I just pretty much finished that list in an Excel spreadsheet of who's allowed to do what.
Somebody asks, is a tolerance break amongst daily users helpful for orgasm and sexual satisfaction? Well, that's a really interesting question too, and it presupposes we know something about the effect of cannabis tolerance on sexual health, and we don't really. I will say that number one, I think tolerance is a significant problem that is underappreciated in the cannabis community, and that ultimately one of the fundamental issues with tolerance is that the way in which tolerance comes about undermines the effectiveness of the endocannabinoid system, because it's caused by downregulation of receptors in response to excessive amounts of exogenous cannabinoids. So in general, I think that working to decrease tolerance is vastly important. That said, amongst my patients, I don't actually suggest tolerance breaks, because, you know, if you're using cannabis for recreational purposes and you decide that it's taking too much or costing too much to get high, so you're going to lay off for a few weeks or a month or something like that, that's a very reasonable sort of self-inflicted process, right? But if you're using cannabis because you're sick, in one form or another, then the idea of going without for some prolonged period of time seems particularly cruel and unusual. So instead, I tend to work with people who come to me at higher levels of use and tolerance to wean that back slowly over time. And what we find is that, generally speaking, people do better, meaning they get a better therapeutic benefit at lower doses. And so maybe by extension, we could say that patients might actually do better sexually with a lower dose and a lower tolerance, but that's not something that I've either observed or shown in any studies yet.
We do have another question. It's about, will cannabis use delay the timing of the orgasm?
I think that the best answer I can give to that is it will delay orgasm in males if they orgasm too soon in general. And it also helps advance or make less delayed in males who have trouble achieving orgasm. So there's sort of this kind of regression towards what we would hope for. And certainly that's not across the board, but that's been seen. I'm not sure we can really make the same kinds of statements one way or the other in women, other than to say that they report greater frequency and intensity and satisfaction. I don't think we've really looked at what that time course is, except to say that they are achieving the orgasms in the time frame commensurate with their partners, who may or may not be using cannabis. So perhaps we can infer that there's some greater speed. Suzanne, do you have any more insight into that?
Thank you. One of the thoughts is that it actually, when we talked about frequency, we're also talking about multi-orgasms. So even though that's a little off the point of the delay of the orgasm, they're more likely to have more orgasms from the cannabis use. And for some women, it didn't work for them, meaning that they didn't really want the cannabis. Maybe they talked about how if they used too much, they couldn't focus. Most women said that it took down their walls. The women that had sexual abuse histories, that cannabis took down the mental walls that they could then enjoy, that would usually keep them on alert. And then many women talked about how they could actually focus. So the focusing could, it could work both. It could. My answer that came to me when you read the question, Kelsey, I think it was Kelsey or McKenna, when you read the question, was it depends. It's someone has to find the right dosage, the right timing, like develop a practice to see what actually works best for each individual.
There's an interesting question in here that is, does route of administration influence the intensity of female orgasms regardless of the time course? That's interesting. And I wonder if that's something we can pull out and look at again. I'm not sure that we have really intensity as a question. No. So
we had frequency. We only had frequency, frequency, ease, and satisfaction. But yeah, we can pull the data. Study. Pardon me?
We'll have to do another study.
Yeah, it's a good question.
Yep. I guess I can answer this anecdotally and say that that while I stand by my original statement that inhalation is better for the logistics, especially when you start to talk about partner relations, in terms of the effect that's reported, I think they're sort of equally efficacious. So I would assume that would be true also around the intensity. Okay. There was another question about, is there membership for professionals? And the answer is absolutely. As much as we adore our students, the professionals are the core group, and we welcome all professionals. As Sarah put into the chat box, you can go to the website and find out about that process and what you get for joining, and all of those kinds of good things. And next week we do our mentorship event, so that should be interesting. And if there are people on the professional side that want to join that, they should let us know soon.
That's actually this Thursday.
It's this Thursday. Yes, you're correct. Yes. I'm a week behind. So it's this Thursday, that being 2 days from now. And if any of you probably all, if you are on our mailing list at all, probably already got an announcement for that, with information on how to RSVP. But in short, if you didn't get that and you'd like to participate, you should just email your interest to Kelsey at info@cannaspecialist.org. And I guess I could throw that into the box here. especially if I could type. I think there are a few questions in here that we didn't get to, but I think we've kept people a long time. So I think perhaps we should call it an evening, and anybody who wants to ask the questions that they think of now or later, they can always email, and we'd be happy to get back to you guys. All right, thank you all for coming.
Thank you
Thanks,
very
everyone.
much.
Have a great night.
Take care.
Thank you.
Thank you.